Pediatric Innovation Training Capsule. Today it's our third capsule, and we will talk about women innovators and female leadership in pediatrics. So this training capsule will last 1 hour, and the session will be recorded. And please have your microphone muted during the presentation. Even if at the end of the session we will have the presentation first, and at the end we will have a Q&A where interaction is more than welcome. So please don't hesitate to use the raise hand option for a question or comments to our speakers, or use directly the chat. So just a bit of introduction to what i4Kids Europe is. So the context is pediatric innovation is still elusive in Europe, and health innovation still tends to focus on elderly people, and children are treated using adult devices adapted by their clinicians, for example. So in this context, there is a clear lack of European focus on pediatric innovation. And it also arises that there is a fragmentation of the ecosystem in Europe. And that's why a European Pediatric Innovation Network is needed. And that's why what i4Kids Europe aims to do. So for that, we have this Origin Europe project that started last year in 2023 with the partners that you can see here, from Finland, Latvia, Poland, Denmark, and Spain. The aim is to enlarge the current i4Kids initiative from Hospital San Juan de Deo to allow synergy and reduce difference between strong and emerging innovators ecosystem, as well as strengthen the innovation competitiveness of the European pediatric sector. So the current outcomes that we have is we had our first Pediatric Innovation Day at European level in Warsaw, and we will have the second one in Riga in September 2024. And we currently have this 12th Pediatric Innovation Training Capsule, this being the third one. And we focus it on the challenges that are existing. And today's challenge that we will tackle is really women in science. Here you can see a map of the percentage of women employed in science and technology in 2022, where you can see clear disparities. I put also some numbers to give a context to the capsule of today. For example, in the US, you have a proportion of women matriculating as first-year medical students exceed that of men with 51%. We also have, in pediatrics, 63% of physicians and 57% of academicians. And on the other hand, in Europe, we have other numbers, more in the entrepreneurship side, with only 20% of entrepreneurs in Europe, which are women. And a strong number also, which is 94% of investment in startup from Central and Eastern Europe are directed towards company led solely by men, 94%. And in Spain, within hospital, you have 74% of professionals which are women, but the representation among service chiefs was of 24%. So I think this number gives quite a good context to this capsule, where we count with Christiane Gross, which is international business developer at LactApp, and Beatrice Jobst, with the senior data scientist at Kriba. So we are really glad to count with you. So we'll talk about this quest for gender equality. We'll explore in this capsule so the female leadership within pediatrics with these two inspiring innovators. and we will talk about this the leadership style and the relation that gender can have in a branch such as pediatrics. So without telling more about it, Beatrice, the floor is all yours.
Okay, thanks a lot, Charlotte. I might share my screen now.
Sure.
Okay. Hello, everyone. Thanks a lot, Charlotte, for this introduction, and especially thanks to the Association i4Kids Europe for inviting me to this marvelous training series capsules. Today, well, first of all, my name is Beatrice Jobst, as already Charlotte introduced me before. I am senior data scientist. I am the head of the data science department at Kriba. Kriba is a health tech startup company based in Barcelona, Spain. And today I will be talking about a little bit what we are doing in our company, namely the acceleration of the screening of infections, and especially focusing on combating bias and inequities. First of all, I would like to draw your attention to the bias which exists in healthcare today. So there are differences in diagnosis, treatment, and care for different population groups. This depends on which, for example, race or ethnicity you belong to, the age group, your sexual orientation, gender, physical appearance, and disability status. So I've looked a little bit on a few research articles where they talk about this bias for different population groups, and I've found quite a bit. I will show you some examples. For example, Black patients are less likely to receive pain medication, and they receive, in general, fewer therapeutic procedures as opposed to white patients. Obese patients, on the other hand, receive shorter visit time by their medical doctors, and the emotional rapport with their medical doctors is affected. Transgender people, for example, face a lot of prejudice and discrimination, even by their healthcare practitioners. And women, of course, just to name a few points, on general receive less pain treatment. They are more likely to be referred to mental health services when they come to their medical doctor with another health problem. They suffer treatment delays and also receive suboptimal treatments. And after the age of 50, they're more likely to die after a significant disease. So this is just to name a few aspects and a few facts that I have found in different publications, but we can have this list go on for sure. The question now is, why does this bias exist? What is the cause of this bias? So I think we need to go back a little bit and think about who are the ones who are creating the science, which is the basis for what we see in healthcare practice later on. So we need to go back and think about that that there is already an inequity in who is creating the science, the different population groups of what later on results in the healthcare practices. Because for centuries, the main standard patient has been male and white. So this is what a lot of healthcare practices are still based on today. So if we look at some statistics, for example, as already Charlotte pointed out before, the female representation in STEM education, if we start at an education level, STEM is short for science, technology, engineering, maths. We already see that of all the graduates in STEM education fields, this is an EU statistics, on an EU average level, only 1/3 of those graduates are women. So this is already where we see a big inequity between gender. When then we go to the employment rate, this is now taking statistics from the US from last year of women, but I also would like to apply my whole story a little bit, not only limit myself to gender imbalance, but also to other ethnic minorities, because these are also the ones who are affected by these kind of biases. If we look at the distribution of male versus female generally in the workforce, we see basically almost equal distribution. But then when we look at who is in the STEM workforce, we see that there is a shift to male predominance. A little bit the same goes for race and ethnicity. So above, we see here the distribution of different population groups in the workforce. And then we see that in the STEM workforce, it is shifting towards more white people, more Asian people, and less, for example, from the population groups Hispanic or Latino, or Black or African American. So these are all facts where we have these kind of equalities, which are facts. There are statistics, so they're visible. Then I would like to bring your attention also to a phenomenon, which is something very interesting to look at and also very concerning, which also goes in the way of what Charlotte talked about in her introduction, which is called the glass ceiling phenomenon. So when we look at the percentage of women in STEM occupations by seniority level, so we look at entry level and then go up the ladder, we see that all the time, the higher up we go, the less women we find. So there is at some point where this is why this is called the glass ceiling effect, that women reach a kind of ceiling where they cannot go beyond, evidently. So if we look at that only 1 out of 3 STEM educated women occupies C-level positions, so chief level positions. So if we take all these facts together, we see that there is still existing big gap inequity and gender maldistribution of who is producing the science, which then later on will also definitely result in this bias we can observe in the healthcare system. So now I would like to talk a little bit about my personal case. So me as representing to some extent a woman working in science, working in a tech field, which is mainly male dominated. So first of all, I would like to present a little bit about myself and talk a little bit about my personal story. As I said before, I'm the head of the data department, data and artificial intelligence department at Kriba. I have a background in mathematics and a PhD in computational neuroscience. I have several years of professional experience as a data scientist in different institutions and companies. And then I would like to detach also that I'm the mother of 3 little girls aged 2 to 7 at what I could call my other company I'm working at, since this is my other full-time job I'm doing at day and night. So what are the values I'm representing and I'm looking for when I look for a workplace, especially in the sector I am working at? First of all, for me, it is very important that there is innovation, because this is the background I'm having. This is my scientific academic background, which leads me to a place where I need to be in a place where we do innovation. Another very important factor for me is that the work I'm doing is having a global impact. So for me, accessibility, inclusivity, and equality are really words I would like to underline. For me, it is important that what the project or the science, the technology I'm working on is reaching different kinds of population groups, not only one type of population group who are, for example, fortunate enough to be able to afford a certain technology. I want to reach different population groups in different settings. I also, especially as a woman, I want to be relevant in the project. I want to be do work that matters in the project. And then I think this is, especially as a woman, a very important factor. I want to be given the capacity to decide. So to have something, to have in my hand also decision capacity, so that what I am deciding is being heard in the company or in the place I'm working at. And also, of course, I would like to share the values with my company I'm working at. So for me, this is something really important, that especially work-life balance is something really important for me, also due to the fact that I'm a mother, but also under other factors. The policies, they need to be the right equality policies in place. The recruitment processes, they need to be transparent and fair. And I wouldn't want to be working in a place where I evidently can see the glass ceiling phenomenon I was talking about before. So Are these values I am representing, are they reflected in the mission of the company where I'm working at? So I will now talk to you a little bit about the company, what our mission is, and what we are doing. In Kriba, our mission is the global democratization of the detection and the monitoring of serous fluid infections. So what are serous fluid infections? What are serous fluids to begin with? Serous fluids are those fluids in our body which are transparent. For example, the cerebrospinal fluid, which we have in our surrounding our brain and in the spine. For example, the peritoneal fluid, the fluid which we have in our eyes, in our joints, the amniotic fluid. All these fluids are called serous fluids. So what we can see here is when the regions of the body which are close to these serous fluids get infected, we can see an increase in white blood cells in these fluids. And this is what we are working with in Kriba. So we are detecting in a non-invasive way white blood cells in those serous fluids using high-resolution ultrasound, innovative coupling materials, and artificial intelligence. So we designed a device which is capable of seeing white blood cells in these type of serous fluids. So what are the main areas we're working at? So our current applications are infant meningitis, peritoneal dialysis-related peritonitis, and uveitis. I will now go into more detail into these applications. So infant meningitis, why is this relevant? So first of all, what is meningitis? Meningitis is the infection of the meninge, which is a tissue which we have just below our skull, and the surrounding, the adjacent areas. So the standard diagnostic procedure is through a lumbar puncture, where the cerebrospinal fluid is extracted directly from the spinal cord. The problem with this is of course, it is an invasive procedure, and what we can observe is, especially in infants, there is the big problem that it is part of a protocol that lumbar punctures are performed in certain when we need to rule out meningitis in a lot of cases, and in a lot of cases it is coming back negative in 95%. So this of course is creating a lot of unnecessary invasive procedures. It is highly cost inefficient, of course, but then on the other hand, in low and middle income countries, we have the opposite problem. We have a lot of misdiagnosis because of meningitis which go undetected, which leads to a lot of mortality and permanent disabilities worldwide. So what we are proposing in Kriba is, with the device we are designing, it is a non-invasive way of detecting an increase in the white blood cells, which is the diagnostic procedure of white blood cells in the cerebrospinal fluid. And we do that directly through the infant fontanelle. So we measure with the device directly through the infant fontanelle, which is a completely non-invasive procedure. We've performed a proof of concept study in several hospitals in Spain and also in Mozambique, and we have reached 100% sensitivity of detecting meningitis cases and a little bit over more than 90% of specificity of detecting the controls. We have efficacy study going on in 8 large volume hospitals in Spain, in Morocco, and also in Mozambique. And in line of this, I would like to highlight our policy of social and gender inclusivity, because this is what is really important in Kriba, is we apply our technology and include in our study design different kinds of income settings. These are the target end user are different kinds of income settings, and also we include different kinds of populations in our studies. So, and of course, we try within the means of our possibilities to have gender balance in our studies. Next, our next application is peritonitis in those patients who are treated with peritoneal dialysis. So what is peritoneal dialysis? This is a form of dialysis as opposed to hemodialysis for those patients with kidney disease. So this is a home-based treatment, so it's very practical, and there is a growing market to it. The main problem is with this treatment is that in a lot of cases, it leads to infection. It leads to peritonitis, which would be an infection in the peritoneum, in the inline tissue layer lining our belly. And this is then the main cause of transfer to in-clinic hemodialysis. And here I would like to highlight again our view of how we would like to reach different end users with our product, because peritoneal dialysis utilization in Spain, in a high income setting like Spain, for example, is utilized only in 5 to 10% of dialysis patients. But in another income setting like Mexico, for example, it is used in 75% of dialysis patients. So this is how we want to reach different types of populations. Here we propose to measure directly external from the body in the dialysis bag, which contains the liquid which is going out of the body during dialysis. And in this way, we can detect early an increase in white blood cells, which is the marker for a possibility of infection. So our lab bench in vitro results have been excellent. And also our first proof of concept results have been very good. And here we are even able to count the white blood cells in a completely non-invasive, automatized manner with the help of artificial intelligence. Also here we have clinical efficacy studies going on in 5 different hospitals in Spain. Last but not least, our third current application is uveitis. Uveitis is an inflammation of the uvea, which is a part of our eye. And here the principle we apply is the same. In uveitis, we observe an increase in white blood cells in the adjacent liquid, which is in the anterior chamber of the eye. So uveitis is the third cause of blindness in high income settings versus the 5th cause of blindness in low and middle income settings. And the main problem with the detection of uveitis is the diagnostic delays, because it is most of the times confounded with conjunctivitis. And there is also asymptomatic patients, especially in the pediatric population, with juvenile idiopathic arthritis. And another main problem in uveitis is the inaccurate grading during the monitoring of the treatment. So how the patients are responding to the treatment, because there's a huge variability of grading between professionals. So with the device we are designing in Kriba, it is completely user independent and accurate. We have obtained single cell resolution on the closed eyelid. So it is on the closed eye, which is much more comfortable than at looking at a lamp with open eyes, which is also more probably usable in an easier way in a pediatric population. And also here our proof of concept results we have performed obtained very similar results to our previous, to the other applications I presented to you. And also here we have an efficacy study which will start later this year. And also here we have a follow-up study planned with a large volume Indian Eye Institute. So just to show you a little bit our team and structure in the company, this is the management team we have within the company. These are the external business advisory board and our external scientific collaborators and key opinion leaders, which are all part of the different projects. And then just to show you quickly also an overview of our internal team. So the different departments, and I highlighted here the department I am leading at Kriba, which is the data artificial intelligence department, which is these 4 members, and these 2 are also part of the data department. So as you can see, we really try at Kriba to obtain gender balance within the company. So another thing I would like to point out, which is something really important for me personally, and especially again, underlining the fact as working as a woman in a science and technological field, the professional and personal growth I am given in a company, and the exposure I am having to the other scientific community is something really important. So I am given in the company I'm working at the possibility to participate in different seminars, talks, in different conferences, congresses, which I think, especially as a woman working in science, is something important for us to have more visibility. So this is something which I appreciate a lot. And I think I'm really fortunate in this sense that I'm given the opportunity and that I can reach these kind of audiences. And also another experience, which I think has been very valuable for me personally, is that I could participate in hands-on patient experience in one of our collaborating hospitals in Morocco, which I think leads to more that when you see what the outcome in the patient is and how the experience with the patient is, you then go back and you have another motivation to continue your work. So just to conclude, we have seen that women and other minority groups are still underrepresented today in STEM fields. We have talked about the glass ceiling phenomenon, which is when we go higher up the ladder, women are less represented. All these factors definitely lead to one of the factors that are leading to the bias which is existing in healthcare today. I have talked a little bit about the case of Kriba, where for us, we try to be inclusive, accessible, and equality, which for us is the normal. Of course, we are completely aware that we don't have a perfect implementation of all these factors in all senses, but for us, awareness is important and we want to improve. Others surely do exist and many more will become normal, but definitely at too slow rate. So what can we do now as a society and as professionals to counteract these phenomena we are observing? So I think we need to start from the early days. Education is the baseline. So we need to educate the next generations against those biases and prejudices we are still observing today. Equity and parity, I think they need to be transversal. They need to go into every concept, into our everyday lives, in everything what we are doing. We need to think about these concepts. So in all the things we are introducing in our companies, but also in our day-to-day lives, equity and parity needs to be on our minds. So in the workplace policies, harassment-free, we need to respect each other. There should be no discrimination. The recruitment processes, we need to use inclusive language in the recruitment process so that everybody feels spoken to. I think work-life balance should be a main factor, and especially independent of the background and gender. Of course, all these factors need to influence our leadership style. And one of the main things for me personally is the awareness. I think we need to be aware of an intrinsic bias we ourselves might have. And also we need to raise awareness to other people, when we talk to other people, we need to make these problems heard. We need to make people see those problems. And then, of course, us who are on the side to be able to be part of the scientific study design, which then will lead to new healthcare practices, we need to be aware about these things. So we need to create the studies in a way that they are unbiased. All of this, I hope, will lead to a more unbiased and equal healthcare for everybody. Thanks a lot for your attention.
Thank you so much, Beatrice, for this really impactful presentation. I think it has been really interesting for all of us with a real case of Kriba. We will keep the question for the end, and now we will leave the floor to Christiane.
Hi, everyone. Can you see my screen?
Yes.
Perfect. So I am Christy. I am the International Business Development Lead at LactApp. Like Beatrice, I'm also a mom of 3, but I have got 3 boys. They are between 10 and 14 years old. I am originally from Italy, from the very north in the mountain, in the Dolomites. This picture is taken very close to there. I've been at LactApp for 4 years. I've been LactApp's number 10 employee. But I'm the only one who physically sits in London. I am based in London at the moment. LactApp is based in Barcelona in Spain. And I was also LactApp's first international investor and number 10 team member. And the story of LactApp is very beautiful, but I don't want to tell it myself because I think the best is you hear it from our co-founder. So I hope you can hear the video now.
LactApp is the first app dedicated to motherhood and breastfeeding, which strives to answer any questions women may have related to breastfeeding in a very personalized way. When my daughter was 5 weeks old, we were both in a terrible accident here in Barcelona. I couldn't walk, I couldn't hold her, I couldn't take care of her or my son. I didn't see my daughter for 10 days after the accident, and I was breastfeeding at the time. I'm Maria Berruezo, co-founder of LactApp. I had a lot of difficulties breastfeeding my first child, and it was difficult for me. It was hard to get the resources I needed, but I did find Alba. She was leading a support group in my area. She was amazing. She was spending hours helping women all around.
Las mujeres tienen dudas acerca de la lactancia y la maternidad a todas horas. A las mujeres les cuesta encontrar comunidad, les es difícil encontrar también información relevante acerca de la lactancia. Soy Alba Padró, IBCLC y cofundadora de LactApp.
I wanted to breastfeed, and Alba knew, and she wanted to help me. So my husband and Alba brought my daughter to the hospital after the accident. Even though my situation was difficult for breastfeeding, Alba was everything I needed. And I thought, if everyone had this personalized information, this community like I did, if everyone had an Alba in their pockets, I'm sure they could decide anything they want about their breastfeeding journey.
So I hope you. So this is what Maria and Alba did. Basically, they downloaded Alba's brain in an app. And this is the picture from the beginning, where they actually sat down in a cafe in Barcelona, and Maria started to ask the question, Alba started to put the answer. They put it in a spreadsheet, in an Excel. Afterwards, they put it in an app, and in 2016, they launched their first MVP. And thank you to Amazon Web Services for making this video for us. Hang on, I'm just trying to move forward now to the next slide. Oops, I missed one. So this is our two apps. We have launched LactApp for mothers, which is the breastfeeding expert in your pocket. It's on the left, the light blue one. It's available in Spanish, in Portuguese, and in English. And you can download it all over the world in all for iPhone and Androids. And then something interesting happened as well. We found at some point that in our app, there was a profile of a mother with 10 babies under 6 months old. And we were like, that's not possible. A mom cannot have 10 babies that are under 6 months old. So we researched a bit, and we realized that it was actually healthcare professionals who used our app for their patients and for their consultation room. So what we did is in 2021, we launched LactApp Medical, Lactation for Professionals. It's a different app only for healthcare professionals with a much more medical tone and with information tailored about lactation medicine, especially for healthcare professionals. And both of the apps are available to download for free for the basic functions. And then there are always free premium functionalities where you can pay for a premium subscription. In the case of the app for mothers, it's the video content that is a subscription. And also it's an in-app chat channel where the mothers can actually talk and write to our experts inside LactApp. And yes, so far we've had over 1 million downloads from all over the world. We have around 50,000 monthly active users, and we have sold over 25,000 premium subscriptions. And now, from when I started, we were 10 people. Now we are 30 people in the team. And we have opened in October 2023, last year, we have opened the LactApp Barcelona clinic, not far from the Sants train station. And there we are the first integrated lactation care clinic. There's not many of those around the world, actually. And you can find mothers can find their lactation consultants. There is even a tongue tie clinic where tongue tie surgeries happen. We have physiotherapists specialized in for babies. We have physiotherapists for pelvic floor. We have psychology, yeah, and other functionalities to see in person there. And you can also book virtual consults. And what do our users say? Well, 75% of the users say that LactApp has actually prolonged their breastfeeding journey. And we know that 9 out of 10 of our users have actually avoided an appointment with a doctor thanks to clarifying their doubts with LactApp. Because many times it's that question, is this normal or is it something I have to go to the doctor about it? So we clarify and we flag up when a doctor is needed. But let's go back to the problem. We know that mothers desire to breastfeed. They desire a breastfeeding journey because over 90% of mothers worldwide, and especially amongst the developed, countries, in the rich countries, as well as poor countries actually, over 90% of mothers want to breastfeed. But yet, by 3 months, 60% of them have quit. And this is despite the World Health Organization actually recommending 6 months of exclusive breastfeeding for the first 6 months, and then breastfeeding until 2 years as part of a healthy diet. So what happens? Why? Is this really only a personal choice of the mothers? What happened that from 90% we come down to only 30%? So, as Maria would say it, the first challenge we had to face is that we are the no sector. We are the no industry. Because when breastfeeding fails, the industry wins. And so I've put here a picture of the mother. The mother in her maternity journey gets a lot of different information from a lot of different people, but we have to consider that sometimes this information, whether it is online, whether it is a magazine, sometimes they are biased by commercial interests. And I don't want to go into these details, but mothers are a very lucrative marketing target. I used to work in business before. I know what I'm talking about. And so I don't want to go more into this topic, but the forces behind personal breastfeeding choices are actually very complex social business forces. And I would like to point you towards an amazing book by a journalist and maternity activist called Kimberly Seals Ellis. She has written a book that's called The Big Letdown: How Medicine, Big Business, and Feminism Undermine Breastfeeding. And we're not talking at all about personal choices about mothers. This is about the bigger picture of society. I really recommend this book and really recommend her following as well, because she is really advocating a lot for the Black community as well, and has got a lot of answers and ideas on how to improve Black maternal outcomes as well, which we have heard before. There's a huge bias for their maternity and their baby's health outcome as well. Black moms are 5 times more likely to die in America in childbirth, 4 times more in the UK, and where I'm based in London. So another challenge we had to come and face was that people were saying breastfeeding is easy. And also that people were thinking healthcare staff is trained to support breastfeeding mothers. Well, breastfeeding is not easy. As you see in this picture, breastfeeding is an acquired skill, a learned skill from the mother. It's instinctive for the baby, but not instinctive for the mother. Mothers need help, they need support, they need other women and professionals who actually know what it's about. So in this picture, for example, you see she's trying to achieve a good latch, and it's not so easy. It's just trying to achieve a deeper latch. So what about healthcare professionals then? We asked last year, we published for International World Breastfeeding Week, we published a survey that we asked to the healthcare professionals in our network. And we asked, what training do healthcare professionals actually have in lactation medicine? And so we had around 1,300 professionals answering. 70% of them were from Spain, 20% from Mexico, 3 from the US. But I can tell you the picture is like this all over in the world. So We asked, do you consider that you received enough preparation in breastfeeding during your formal training? And 93% of them said no. And we asked them, how many hours of breastfeeding training did your curriculum offer? And 40% of them said none at all. And then we asked, where does your personal knowledge of breastfeeding mainly come from? And 60% of those healthcare professionals said it comes from my own training, and 25% said even from my own experiences. So we cannot rely on the own experiences. And that's why in LactApp we also work on education for healthcare professionals. We have an offering that's called LactApp Academy. You can find on our website. We do a postnatal degree, postgraduate degree in lactation medicine in partnership with the Ramon Llull Blanquerna University in Barcelona. And unfortunately, those training sessions, we also do just some training sessions that are like just a one-off or also in person. So please check out our website for training. Unfortunately, they're only available in Spanish for now, but we are working on more training. So another challenge that we are facing is the question, do we actually know enough about lactation medicine? And we know that research in women's health is actually really lacking funding and is really behind of research in men's health. I just pulled out a statistic that only 2% of medical research funding goes to women's reproductive health. Only 2%. And this despite that 1 in 3 women have a gynecological or reproductive health issues. So here in the picture, for example, you see like a worst case scenario for us in lactation medicine. The image is about a breast abscess. A breast abscess is a complication that comes after a mastitis hasn't been resolved, and the mastitis is an inflammation in the breast. Now, we've done a little exercise looking for research in the topic of mastitis. So there is a website that many of you might know that's called pubmed.gov, where you can find all different research papers. So we're typing into it mastitis, and let's see what is the result. Well, the result is that for mastitis, you can find nearly 11,000 research papers for cows and only around 1,000 research papers of mastitis in women, and then 800 in sheep and 650 in goats. So what does this tell you? This tells you that mastitis in cows is resolved because the industry earns money when lactation succeeds. In the case of cows, making milk. In the case of women succeeding with breastfeeding, there is no economic gain. So unfortunately, we're only scratching the surface. And so I wanted to shed a little bit of light as well. Despite us being a small startup, we have always tried to put money into and funding and our efforts into research as well. You can find our published research paper on LactApp research. We actually also do, we have also done some research on mastitis because exactly there is where we really need more. We've published in the Journal of Breastfeeding Medicine, in Midwifery, in the International Journal of Medical Informatics, Nursing Inquiry, and we are working on this to shed more light, not on the benefits of breastfeeding and the actual composition of breast milk, but in actually the problem, solving the problem that women practically face when they are breastfeeding, for example, with mastitis. And I wanted to talk a little bit about the leadership style of our company as well. We have 3 founders, Maria and Alba, who met in a volunteer breastfeeding support group. Alba is a IBCLC, but she is also a maternity influencer and author. She has written 5 books on breastfeeding. I think she's published the 6th right now that's coming out about breastfeeding and returning back to work. And then there is Enrique as well. And although Enrique is actually a good friend of Maria, they knew each other from university. Enrique works a lot on the technological and on the finance side of our team. But I wanted to shed light on how the three work together and how the three work with us as a team. Together, they are actually having a very equal relationship. It's not that Enrique is the CEO and every decision has to go through to him, because it's not a hierarchical organization like this. I would say the three of them really work as a team on a real equal level. Every one of them they share, so they divide the topics of expertise, and then they decide the relevant things together, or depending on which topic each one decides in their own field. So Maria, for example, is the Chief Operating Officer. She is the main person with staff. She is the main person behind the UX, the app development, and Alba is the head expert doing the clinical side. And I would also shed light of they are very different leaders than from what you have ever seen. Maria, for example, is a very introvert person. She would sit in a meeting and be the quiet one, listen, and then actually ask you the question and ask, what would our users do? She will never lose the sight of our users in the end. And yes, I'm proud also to say that we are not only a majority female founded company, we are also a majority female owned company. So over 50% of the LactApp shares nowadays are owned by women. So I would say this is a different way of leading a business. So if you are looking into founding your company, don't scare away. It doesn't have to be always the typical way. There is many forms of leading a company. Yeah, this is a few of the companies we already work for. For example, we work with Adeslas. Adeslas is the #1 Spanish private health insurance company. And if you are in Spain and you have a Adeslas membership, you can have the LactApp Premium subscription for free. They will pay it for you. So for 2024, we are looking for increasing and do more B2B partnerships, for example, with Adeslas, but also in other countries. As I said, the app is available in English as well. And we are looking to do pilots with other national health systems or hospitals or clinics who would like to try a LactApp in their clinical setting. So thank you.
Thank you so much, Christiane, for your presentation. I think both presentation has been really inspiring. So yeah, thank you a lot for that. Like two really different point of view, but really touch a lot of aspects. I would like to open the Q&A now to take advantage of the time that we have left. I don't know if there is some question from the audience. But if there is, yes, there is a question.
Hi, can you hear me?
Yes.
Yes.
Yes. Yeah, thank you so much. Very interesting presentations. I had a couple of questions. One, because both speakers were, particularly the first speaker was talking quite a bit about inequalities and improving access and so on. Are with these different initiatives, are they thinking to trial them in low resource countries and then make them available free of charge for services that couldn't otherwise, be able to to use them if the research showed that these were safe to use in these settings. And then specifically about the ultrasound cranial scan to look for meningitis, look for white cells in the CSF. It was a small sample size and very impressive sensitivity and specificity, but I was just interested in what the clinical criteria were. So what was the kind of phenotype of people that were enrolled into the study? So were they people with because honestly, like I'm a pediatrician, I worked many years in frontline pediatrics, and often your threshold for doing a lumbar puncture in an infant can be very low because the signs and symptoms can be very non-specific. So it would be important to understand like what was the kind of threshold that they used for deciding who would have these scans.
Okay, thanks a lot. Thanks a lot for the really interesting questions. So first of all, regarding the first question, yes, that is actually our mission. So our mission is to be able to bring this technology to all different kinds of places. So we are working at the low cost option of the device, and to be able to bring it also to low income settings. So this is one of our main objectives, because this is where it is needed the most, to be honest. I mean, it is also really good to have in high income settings, because as I presented before, there is the problem of that lumbar punctures are oftentimes unnecessarily performed. So it is really helpful to have this as a previous screening device, and only then the medical doctor can decide, do I need to do a lumbar puncture then based on the result or not? But where it could definitely save lives is in other type of settings where there is no possibility to perform lumbar punctures because there's not enough trained personnel, or they don't have the possibilities to bring. We see this from our own experience with our collaborations in Mozambique, for example, where we have a lot of problems with the generation of the lab work which is being done there. So there is a lot of work which still need to be done. So this is a setting where our device could really make a difference. So this is regarding the first question. And the next question, yeah, that is definitely an important point. So who was entering into the study, or who is entering also in the ongoing study, is babies with less than 1 year of age. But we are especially focusing on newborn population, so around at least up to 1 month of age. But we have also in our studies we've also seen up to 8 months or something similar. And the basic point is they need to have a lumbar puncture performed. So because this is our ground truth generation, where then we feed our artificial intelligence algorithm with this information, with how many cells have there actually been in the liquid. So this is where we take our ground truth from, let's say. So this is the baseline. And of course, the parents need to sign a written consent that they want to participate in the study. Yeah. And about the threshold you were asking about. So I know that there are different thresholds which are considered as what is meningitis or what is not meningitis. Right now, we have tested our sensibility, goes up to, in meningitis, around 30 cells per microliter. This coincides with the threshold which is applied usually in newborns. So up to 1 month of age, the threshold which most centers are using is 30 cells. In prematures, it's 40 cells. Then it goes down to, depending on the center, depending on the institute, it can be 9 cells, it can be 5 cells. This depends a little bit on the practice. This is a sensibility which we don't reach right now in meningitis. So we have tested it up to 30 cells per microliter. Yeah.
I think she answered in the chat, but yeah, go on if you can talk better.
Yeah, sorry, no, thank you so much. No, my question about the threshold was more the clinical threshold to perform the scan. Was it babies with fever? Was it babies with fever and vomiting, or was it also including more specific, more neurological symptoms that they had? So what was the kind of clinical? So I understand the age criteria. Was there also some clinical criteria to enroll babies into the scan? Because it would be important a lot of babies will present with very non-specific signs early on, which is why you do get a lot of negative lumbar punctures, because often, as you probably know, they present with things like fever, vomiting, etc., which are quite non-specific, and then later on they might get more clinical signs like bulging fontanelles or so on. So it would just be interesting to understand what your clinical threshold was for enrolling babies into the study.
Yeah, so it's basically that. So that when clinically speaking, they considered that the lumbar puncture was necessary. So that only in this case we did the scan. So when there was a baby with fever or symptoms which made suspect meningitis, they performed the lumbar puncture, and then we would contact with them and we would say, okay, this is a baby where we will do the scan. So we had a 24-hour window after the lumbar puncture to do the scan. The centers then were doing the scans by themselves. Yeah, so this was kind of the inclusion criteria, the clinical criteria from the medical doctors for them to say we do a lumbar puncture or we don't. That's basically the criteria.
Thank you. I think in both cases, you have the email of Beatrice of Christiane if you want to contact them later. As I see the time is advancing, I just have maybe a last question for you. So do you have an advice to share with future women? So maybe for Christiane, maybe more in the entrepreneurship journey that you want to share with the audience?
Yes, I want to just share an advice that funding for female founders is very complicated. So don't get disencouraged if you knock a lot of doors and you don't get funding. I think a good idea is to try to find other revenue streams. So for example, what we did is our founders started to do actually educational training for healthcare professionals, or they started to do teleclinic, even though that was not the end vision. Our end vision is to really make an app that is scalable worldwide. But we did a lot of other things around, also for that, to bootstrap and to get a revenue stream to actually fund what you are doing. So don't get discouraged because funding is very hard. Maybe apply for the public funding, because I think there's now the European Union is now doing a lot of public funding as well. Maybe apply for specifically female founders. There's a lot of networks. There is a lot of areas where you can get mentoring. But from my experience, women don't really need the mentoring. From my experience, women just need money. Because from my experience, I think women are just as much set up to start a company as any man, if sometimes not more. So I think yes, don't get discouraged. And it is possible even in a field like ours where funding was impossible. Our founders were volunteers in breastfeeding support groups, and they deliberately wanted to take this work out of the volunteering and found a tech company. So yeah, don't get discouraged. And there's a lot of women in tech. We are here to to show it that it's possible. It can be done. It can be done.
Perfect, thank you. An encouraging message.
Exactly.
Beatrice, do you want to add something?
Yeah, I can talk a little bit more from a science point of view. So women getting into science, I think one of the main factors is because we always have in our minds that this is something male dominated, that it is too complicated, that it is too, so this is kind of I think it already starts when we are young. We get scared away from these topics, and I think it is really important to that we raise this awareness and that we show all the possibilities. Because if then somebody's not interested, they're not interested, no problem. But many women definitely get scared away because they think it is not for them. So I think we need to encourage that we need to encourage that we show the possibilities and what the outcomes can be, and what also the professional future can be. You know, so I think this is the main thing I would like to say. Yeah.
Perfect. Thank you a lot. I don't know if there is any other question. If you want to add your email in the chat, I see someone ask about it. I would like just to share with you, if there is no other question. You were talking about funding, and you were talking particularly about public funding. So I would like to take the opportunity to present you the Women Tech EU, which is a call dedicated to women to create a more balanced entrepreneurship ecosystem in Europe. There will be 4 successive funding calls for 160 women that led deep tech startups in Europe and in Eastern Europe associated country. They will receive money, so 75K in funding, and also a personalized business development program. And the first call just opened yesterday. So if you are interested, or you know some people who would like to participate, please share it with you, or they can also reach out to me directly and go to this womantecheurope.eu page to know more. So I think it will be a really good opportunity, as Christiane mentioned, to start with public funding. And if there is no other question, you can reach out to our 2 speakers that I would like to give a huge thank you, because it was a really great presentation and great insights. And also thank you to the audience. The capsule has been recorded, so if you want to share this capsule with some other people, we will send the link by tomorrow. And we would like to tell you that we will have another capsule next month on regulatory, the regulation in pediatrics. So please keep up to date. You can follow us on LinkedIn, or you can also join our innovators community, where we have a lot of news call related to pediatrics, and you can just scan the QR code that you can find here on the screen. So without telling more, thank you a lot. Thank you, Beatrice and Christiane, and hope to see you soon.
Thank you so much. Bye-bye.
Thanks a lot. Thanks a lot.
Thank you.
Bye bye.